Hello and Namaskar. You know that India is the global number 2 in diabetes, and our aim is that India doesn't become the diabetes capital of the world. In fact, our current endeavor and aim is to make India the diabetes care capital of the world. We are in 2018 and we are constantly getting newer and newer recommendations from different associations across the world. So what I want to do with you is take you through a journey of different guidelines which exist by different medical societies in the reimbursed world. See, in India, when we tell somebody to follow something, they usually are resistant to follow it. But most of the guidelines across the world are evidence-based. So let us look at an overview of the interpretation and implications of various 2018 guidelines in diabetes. Now you know that recently in this year, ACP came out with some very controversial guidelines, and let us look at each of the points which they came out in their guidelines. ACP is basically standing for American College of Physicians. You know that in India, API has come out with a guideline long time back and they are in the process of revision. Then of course IDF has their own template which they came out and they are modifying their guidelines for primary care. And then of course the American Endocrinology Association and AD and the ESD have come out with their draft recommendations of the guidelines which will be published in October in Berlin and the ESD. So let us look at ACP. ACP is the American College of Physicians and they came out with their guidance. Their guidance said that the key treatment of diabetes is individualization. So their first statement in their guidance of ACP, American College of Physicians, is clinicians should personalize goals for glycemic control in patients with type 2 diabetes and discuss the pros and cons, effects and side effects, benefits and harms of pharmacotherapy based on different characteristics. Look at patient's preference, patient's compliance, patient's adherence, patient's overall general health, frailty, life expectancy, treatment burden, and of course cost of care. So remember, this is very relevant, and this particular guidance statement number 1 is very apt. It talks about personalized goals. So somebody is a diabetic which is recently diagnosed, very young, you should do tight control, you can go up to 6.5. But somebody is a senior citizen, limited life expectancy, multiple complications, you can go a little easy. That is what is the guidance 1. The second guidance is that clinicians should aim their A1C level between 7 to 8% in most patients with type 2 diabetes, and this is very controversial. I think most of the global associations keep it at 7. That 7 to 8 might be only relaxed in special situations like limited life expectancy, people with lot of comorbidities, that is where it will apply. And therefore this particular part of their guidance statement got into a lot of controversy, and we as practicing clinicians, endocrinologists, diabetologists recommend that try to keep it your A1C to 7 as much as possible. You might relax that norm a little bit only in special situations where there is limited life expectancy and other situations. The third guideline and the third statement, which is also very controversial from ACP, was that clinicians should disintensify pharmacotherapy with type 2 diabetes who achieve an A1C less than 6.5. Again, this was highly controversial because you cannot stop treatment or disintensify treatment when the A1C comes below 6.5%. This was in an era when diabetes lowering drugs caused hypoglycemia. Two groups of diabetes drugs cause hypoglycemia, secretagogues and insulin. And therefore, you need to be careful in elderly population, people with brittle diabetes, recurrent hypoglycemia, then maybe you might need to desintensify below 6.5%, but not in everybody. So again, that was a caveat. So guidance number 2 and 3 of ACP have to be taken with a pinch of salt. And the final guidance which came from ACE, which predominantly is relevant, is that clinicians should treat patients with type 2 diabetes to minimize symptoms related to hypoglycemia and avoid targeting A1C in people with life expectancy less than 10 years due to advanced age, residence in nursing homes, chronic conditions like dementia, cancer, end-stage kidney disease, COPD which is severe, or heart failure which is severe. So remember, this is a very apt guidance statement from ACP that if you have limited life expectancy less than 10 years, particularly if the age is more than 80 years of older, somebody is residing in nursing home or is terminally ill, has chronic conditions like dementia, cancer, end-stage kidney disease, end-stage lung disease, or end-stage heart disease or heart failure, then probably you can go easy and do not harm. So Hippocrates says primum non nocere, which in Latin meant that in English, first of all, do no harm. So I think ACP guidance is a relaxed guideline. Disintensification and 7 to 8 has been a little controversial, but the last guidance statement of theirs, where they tell you to go easy on the high risk populations, particularly in elderly above 10, limited life expectancy, people in nursing homes, chronic conditions like dementia, cancer, end-stage kidney disease, end-stage COPD, and congestive heart failure, I think is very apt. IDF has given a global template for different considerations, and their template is very simple. Lifestyle, if A1C doesn't come below 7%, first line could be metformin, but there could be alternatives, low cost, minimal care like a secretagogue or alpha glucosidase inhibitor. And then second line is secretagogue, metformin, and then gliptin, glitazone creeps in. And third line is insulin, and fourth line is basal insulin. But they have a usual approach and a baseline approach. IDF is a very general guideline, it's more for primary care, and they have told each country to adapt it. So in India, RSSD has made their own RSSD wheel about the same. Let us look at the ADA. ADA really came out with their recommendations with the ESD, and their joint statement is now under draft review. And in October 3rd, in Berlin, they will unveil their final guidance. Their guidance was based on some principles. Approach to diabetic patient's attitude, expected treatment efforts, risk of hypoglycemia, disease duration, life expectancy, comorbidities, vascular complications. So remember, you need to be less stringent if the patient is non-motivated, is non-adherent, has high risk of hypoglycemia, long duration of disease, short life expectancy, or severe comorbidities, severe established vascular complications, and limited resources. You can be less stringent. You have to be more stringent and take appropriate action. So action and inaction in ADA is if there's a motivated patient, low risk of hypoglycemia, newly diagnosed, long life expectancy, no comorbidity or vascular complications, and lot of resource system, then it is there. Again, in their guidance statement is very straightforward. Healthy eating, weight control, physical activity with metformin as the first line. And then of course you have multiple paths including sulfonylurea, glitazone, gliptin, SGLT2, GLP-1 and insulin. And then you can intensify it with triple therapy, and then of course multiple therapies. What is unique about 2018 guidelines of ADA ESD is that they have looked at the limitations of A1C measurements, because it's very relevant for a particular country like India. When you are diagnosing somebody with diabetes, we have belts which have malaria, which have hemoglobinopathies like sickle cell anemia. So we have a lot of these HB variants, SA variants, and there are conditions with red cell turnover. And therefore, to diagnose A1C generally, particularly in this situation, may not be a relevant population. And that's very apt in our conditions. Second thing in their 2018 guideline they have recommended is, they have recommended testing for pre-diabetes and type 2 diabetes in children and adolescents, particularly in youth who are overweight and obese with additional risk factors. Then they have added a clarification. While generally not recommended, community screening for special situations may be responsible, particularly it's relevant for a country like India. Based on new data, we know now we have continuous glucose monitoring, and in adults with type 1 diabetes, particularly above 25 and above, who are not meeting glycemic targets, they have recommended glucose monitoring which is continuous. They have also made clear-cut remarks on new recommendations with type 2 diabetes with anti-hyperglycemic therapy because of the new CVOT trials. We know two large trials, EMPA-REG with a positive CV outcome, followed up, and that is category A, CANVAS with category C, and then of course is the leader trial for liraglutide. They have recommended them as a major entity which is there. The next thing which they have put out in their 2018 guidelines is hypertension. All hypertension patients with diabetes should monitor their blood pressure at home. So they have emphasized the need for home blood glucose monitoring, blood pressure monitoring, just like home blood glucose monitoring. And that will eliminate white coat hypertension, and that would improve the medication taking behavior. They have also told that people who have resistant hypertension, you can give an aldosterone receptor antagonist or a mineralocorticoid receptor blocker. They have made the lipid management more aggressive. In fact, the LDL target is going down to almost 50. A diabetic should keep the LDL below 50. And people who have middle-aged with ages between 40 and 75 and above 75, even without atherosclerotic or cardiovascular disease, there is a need to use moderate intensity statin, and that has been officially recommended. So that was the ADA ESD guidance. We will be on the lookout in October for the new guidance and the final draft, but more or less this is where it will look at. The ACE, the American College of Endocrinology and American Association of Clinical Endocrinologists, came out with 2018 their summary statement. They are very clear. Keep your A1C below 6.5 for healthy patients without concurrent illness and low hypoglycemic risk. And people who have lot of illness, lot of risk of hypoglycemia, you can be above 6.5. Then lifestyle is green. If your entry A1C is less than 7.5, you can start with metformin, but you have a lot of other options like a GLP-1, SGLT2, gliptin. All that is green. And they have given a hierarchical preference to SGLT2 and GLP-1 after metformin. And then of course you have gliptin. AGIs are also there in their guidelines, which are very important in India and China. And glitazones and secretagogues with glycides become yellow, but rest are green. If your A1C is between 7.5 and 9, you can give a dual therapy or a triple therapy. And dual therapy is metformin, and then the green combination could be GLP-1, SGLT2, DPP-4, Covalcelum is a bile acid sequestrator available in the US, short-acting bromocriptine and AGIs. And then the yellow is glitazone, basal insulin and secretagogue. But however, sometimes what happens, if patient is symptomatic with osmotic symptoms like polyuria, polydipsia, polyphagia or weight loss, and A1C is above 9%, then you need to give insulin in the catabolic state. But if patient is asymptomatic, even above 9%, you can try dual and triple therapy and then intensify. So that is the crux of the glycemic control algorithm of ACE. In the ACE, they have re-emphasized lifestyle optimization, the team approach of diabetes, the need for weight loss therapies, caloric replacement with meal replacement substitutes. They have made a specific mention of diabetic specific nutrition and its therapy and obesity management and the need to treat obesity. They have also said the A1C has to be individualized based on age, life expectancy, comorbidity, duration of diabetes, risk of hypoglycemia, adverse consequences of hypoglycemia, patient motivation. So whether it is ACP, whether it is IDA, whether it is AD or IDF, whether it is ACE, everybody talks of individualization. And then of course they have re-emphasized the need of SMBG, and they have also told that the choice of diabetes treatment has to be individualized for both patients and medications. We have to look at mechanism of action. We have to look at the hypoglycemia and weight gain potential of the drug, the adverse events of the drugs, how tolerated, how easy to use it is. It is meal independent, meal dependent. We know secretagogues, the alpha glucosidase inhibitors, the glitazones may not be meal dependent. Secretagogues have to be given before meals, the AGIs have to be given with meals, the metformin has to be given after food. But the newer therapies like gliptins are meal independent. Adherence, cost, heart disease, liver disease, kidney disease also play a role. They also looked at severe and non-severe hypoglycemia, weight gain as a priority. They looked at combination therapies, lipid and blood pressure therapies, and therefore ACE guidelines and ADA guidelines tend to be very comprehensive. But remember, we are Indians, and the main summary from all these 2018 guidelines is one size doesn't fit all. Diabetes and type 2 diabetes is a heterogeneous disease. Every type 2 diabetic you meet and see is different, and that patient which you see is different at different times of lifestyle. So what we want to do, we want good glycemic control with early intervention. Second is we have to strategize the glycemic target based on patient safety, and you have to individualize treatment. So remember that the usual target of less than 7% can be amended to a very tight target. But people who have short life expectancy, long duration of disease, frail, comorbidities, advanced diabetes complications, social and educational issues, cognitive dysfunction or psychiatric issues, drug tolerance, access and cost issues, you can go easy on the target of diabetes. As Indians, we have a Make in India campaign. Indians are unique. We have a diverse clinical phenotype. We have different manifestations, cost, complications, access, adherence, our use problems with us. So Dr. Mishra and many of us who are part of this guideline, we summarize an Indian approach to managing diabetes. So when you see an Indian patient with diabetes, look for three things. Is there ketosis? Is there infection or major comorbidity? If that is there, sometimes you might have to start with insulin and move to a tablet. And then look at the BMI. If the BMI is 22, 23 or more than 23, probably, and if there is ketosis, infection, major comorbidity, straight start on insulin. But if it is more than 23 BMI, in absence of ketosis, infection and major comorbidity, you can start with metformin. You might add a secretagogue if the BMI is lower. But in India, we are very lean people also. I see people from hilly regions, Northeast India, many parts of even within the geography of India, people with BMI below 20. And in them, metformin is not the first choice. There may be a secretagogue or insulin or other agents might come there. Also remember, we are a high carbohydrate country. Because we eat a lot of carbs, whether across India, not just south of India, we have a role for acarbose or oligobose. So remember that when we talk of Indian guidelines, look at the BMI. If the BMI is below 20, look for ketosis, infection, major comorbidity, and do not forget the carb of our patients and AGIs. That is the only variation between us and rest of the world. I cannot emphasize that no guideline, no recommendation, no medicine can work without appropriate adherence to lifestyle. And my prevention and treatment mantra for lifestyle is very simple. Eat less, eat slowly, eat on time, eat every 2 to 3 hours, eat the right food, avoid high carbs, avoid high fats, improve proteins, replace partly or totally one of the meals if it is very large. Walk more, try to attain at least 10,000 steps a day. If it is not possible at one end, and if possible, try to do some resistance exercises, because we are sarcopenic Indians, we want to build that muscle mass. Sleep well, sleep on time, and we love to give or take stress, so smile. So I think if you really look at a holistic approach for Indians, because we are so vulnerable, we need to adapt all the evidence-based guidelines from the world. All of them talk about individualization, all of them talk about usual target and amended target, all of them talk about newer molecules, but also talk about patient preference, access, cost, over and above all the other methods which are there. And remember, no medicine in diabetes works without lifestyle. So it's very important to eat less, walk more, sleep well and smile, and take the right medicine. Most importantly, I have a very simple approach to diabetes. Keep your A1C below 6.5, 7 or 7.5. That is the A. B is for blood pressure. Try to keep it below 130 over 80. C is for cholesterol. Try to keep the LDL cholesterol below 50 or 70. D is for diet. Ensure that you eat less, replace one of your meals partly or totally. E is for exercise. And if you do this ABCD approach, I am certain that we will not be the diabetes capital of the world, not the number 2 in diabetes in the world, but we will be the diabetes care capital of the world. Thank you.